This conference will now be recorded.
Are you able to see my slides?
Yep.
Okay, great. I'm going to dive in with some cases and share it with you. Feel free to participate. Feel free to join in and ask questions. It's some cases from the day-to-day work. My name is Shaima Fadl. I'm from Virginia Commonwealth University Health System, and I'm happy to participate today. It's a great pleasure. Starting with the first case. 24-year-old female referred for surveillance of aortic dilation. What's the association with this diagnosis? Is it aorta root dilation? Is it ascending aorta dilation? Is it aortic arch dilation? What do you think? And it is ascending aorta dilation. This condition is a bicuspid aortic valve, and usually it's associated with aortopathy, which is mainly involving the ascending aorta, not the aortic root. Usually the aortic root are more associated with aorta root dilation is associated with Marfan syndrome, but the ascending aorta dilation is more associated with bicuspid aortopathy. This is a patient with the dilated ascending aorta, and this is the bicuspid aortic valve. There is fusion of the right and non-coronary cusps. The way I identify the cusps, starting with the non-coronary cusp, is the cusp that always faces the interatrial septum, no matter where is your orientation. Is it short axis? Is it four chamber? The cusp that faces the interatrial septum is the non-coronary cusp. The cusp that faces the anterior chest wall or right ventricle is the right coronary cusp, and then the left cusp will be the only one left. It's usually prevalent in 1 to 2% of the population, and men are usually more affected than women. This is an example of a left and right coronary cusp fusions, which is most common subtype of bicuspid aortic valve, almost 70%. And the other type is the fusion of the right and non-coronary cusps. The true bicuspid valve, meaning that only two cusps and leaflets are present, is usually very uncommon. It's 5%. And usually we comment on it as medial lateral cusps or anterior posterior, depending on the directions of the cusps or leaflets. Usually, bicuspid aortic valve can be associated with valvular dysfunction, either aortic stenosis, aortic regurgitation, aortopathy, aortic dilation, or aortic coarctation, and dilation of the ascending aorta rather than the aorta. Note that patients with coarctation have a higher incidence of bicuspid aortic valve, but be attentive to that 50 to 70% of the patient with coarctation may have bicuspid aortic valve. It's very common, like in this patient. Also, those patients may need some surgery later on if there is significant dilation of the ascending aorta. So just pay attention to the coronary origins. Sometimes with there is some high origin of the right coronary artery. It's a variation that can be associated with bicuspid aortic valve, and it is referred when the origin is more than 1 centimeter above the STG junction. Surgery is indicated for aortopathy if the size of the aorta is ascending aorta is more than 5.5 centimeter, or lower size 5 centimeter plus risk, either risk of coarctation, risk of hypertension, risk family history of dissection, or the growth rate is more than 3 millimeter per year. The size of more than 4.5 centimeter plus is considered when there is a need for aortic valve replacement. What's the association with this diagnosis? This is another companion case. Is it ascending aorta dilation? Is it aorta coarctation? Is it aortic stenosis? Is it aortic regurgitation? Any volunteer? Any VCU trainee?
Regurgitation.
Excellent. So this is a patient with quadricuspid aortic valve. It's less than, it's very uncommon, 0.05%. And more commonly, it's associated with mild aortic regurgitation. Usually, they just keep an eye on the LV function and usually the regurgitation volume, and usually it is mild. It's compared to the bicuspid aortic valve, is usually not associated with aortopathy, dilation, or aortic valve stenosis, but just the lack of the coaptation of these quadricuspid valves leaves that central hole that causes some mild dilation. Let's dive into another case. This is a 13-year-old man, admitted with femoral, young man, and admitted with femoral artery occlusion that required surgical management. They were concerned that this is a cardioembolic source, so they did an echo, and then the echo showed excessive levoid position of the heart, and the patient was transferred to the cardiac MRI. Any thoughts?
Congenital absence of pericardial.
Excellent. So there's
Congenital absence of pericardium.
yes, great job. So there is excessive leftward location of the heart, and what we call it levodeposition. We are not able to identify the pericardium, and also there is exaggerated movement of the ventricles during the cardiac cycle, systole and diastole. This is excessive movement. And also, you are not able to see the pericardium in any air. And also, the moving to the other sequences, you start to see the lung parenchyma is insinuating in areas uncommon to be seen, like along the inferior wall. This means that the lungs are insinuating along the right ventricle side anteriorly, along the inferior wall of the left ventricle here, and sliding movement, and there is still no pericardium detected. Along with that exaggerated movement of the left ventricle, you see the lateral wall is contracting as if there is it goes to all the way to the posterior aspect of the chest. There is nothing to. And this is another view of the two-chamber view. This is the left atrium, left ventricle, and this is the lung tissue along the inferior wall of the left ventricle. There is no pericardium. There is some epicardial fat here, but there is no pericardium. Also, you can see the lung tissue insinuating between the aorta and the pulmonary artery. This means that this patient has even no pericardial sinuses or recesses. Pericardial agenesis, it's a rare condition, usually asymptomatic. Usually it's most of the time it's complete, but can be partial or foramen type. When it is partial, left defects are more common than right defects. And when it is partial, may mimic ARVC. You can see some protrusion of the ventricular wall through the defect. So pay attention when you see some abnormal wall motion of the RV free wall. Exclude that this is not just a partial defect. Why we care about it? Just we can keep an eye if there's any risk of cardiac herniation, any of the chambers, or some compression. You saw that there is excessive levodeposition of the heart. This means that the veins, the pulmonary veins, are really prone to some compression against the spine, or if there is any excessive compression on one of the coronaries. Imaging features, as we discussed, leftward cardiac displacement, posterior shift of the LV apex, excessive lateral wall movement, elongation of the atria and dilation of the ventricle. They call it teardrop morphology. And absence of the pericardium and pericardial recesses, insinuation of the lung parenchyma, and excessive cardiac mobility. They described it more than 15 millimeter. Usually you would expect 1 to 7 millimeter cardiac mobility during the cardiac cycle. Okay, let's dive into the other case. Any thoughts? This is a stack of short axis, like just two slices of short axis view in the basal segment of the heart. Anyone see any abnormality? What caught my eye is that left ventricle is, you can see some like tissue ridge here. You can see some two opening like eyeglasses. They call it spectacles. This is a two-chamber view. Any thoughts? There is like two openings here. This is the mitral valve. This is the left atrium, left ventricle, and this is a longitudinal view through the left atrium and left ventricle. There is two opening of the mitral valve.
Double orifice mitral valve congenital anomaly.
Yes, this is a case of double orifice mitral valve. It's characterized by two orifice mitral valves separated by a tissue-rich spectacles-like morphology. And there are variable reports that most of the cases can be asymptomatic, but also can be associated with mitral valve dysfunction, either mitral regurg or mitral stenosis. Coexisting congenital anomalies, we need to pay attention to this. Usually any left-sided, any congenital anomaly that affect the left side of the heart, like left ventricle, mitral valve, can also affect the left side, like the aorta, and aortic valve. So we need to pay attention of the association of left-sided pathology, congenital pathology. Sometimes they do it iatrogenic to like narrow as a management of mitral regurgitation, but this case was a congenital incidental found. Okay, another case, 85-year-old man. This is an old patient referred from the cath lab after an attempt of placing a stent in the RCA. And these are the initial CT scan images. These are axial images from a non-contrast CT scan. They were attempting to access the RCA. This patient had an obstructive coronary artery disease on his prior coronary CTA, and they were trying to stent the distal RCA. And because of his age and comorbidities, they wouldn't. They preferred like percutaneous management rather than cappage or coronary artery bypass surgery. But unfortunately, the patient developed chest pain, and they thought that they did something in the cath lab. So immediately they did a stent in the proximal RCA, and they referred the patient for the CT scan. This is the stent in the proximal RCA, and you start to see that there is a high density material along the aortic route, and it is extending along the pulmonary artery wall as well. And it's extending superiorly to the level of the ascending aorta here. This is a retained contrast material within a retrograde aortic dissection. So this hyperdensity is contrast material from the catheterization angio of this patient. And this was images from the post-contrast. Sorry about the noisy images, but there was a dissection flap here in the aorta. This is what we call catheter-induced retrograde dissection after coronary angio. This is, the cath lab is doing more and more complex angio cases. So we would expect that incidence to be rising and to see more and more cases. They call retrograde aortocoronary dissection. It has been reported up to 85% more in the RCA, despite that the dissection itself from the angioplasty can equally happen in both, but as a retrograde dissection of the aorta, usually it's reported more commonly with the RCA. Can be graded as grade 1 when it is involving the level of sinuses of Valsalva, grade 2 when the dissection extends to the level of the ascending aorta but less than 4 centimeter, and grade 3 when it is extending all the way up more than 4 centimeter. Management, usually they know that they dissected the coronary in the cath lab, so they will place a stent at the origin or the ostium of the coronary artery to seal the entry point. So no dissection that goes up to the aorta, but still they will do a follow-up management imaging to make sure. And this patient on the follow-up imaging, the dissection disappeared and everything resolved, so it was a good outcome. The only thing is grade 3, when it is extending all the way up, may progress. That's why they keep on follow-up imaging. Surgery and cappage can be another entity for those patients. But as we learned, that type A dissection referred usually to surgery, but in those patients with retrograde aortocoronary dissection after cath, the management is slightly different because it tends to be in grade 1 and grade 2 at least favorable outcome. Okay, another case. 15-year-old man with mild mental developmental delay, muscle weakness, and chest pain presenting with marked troponin elevation. Any thoughts? Any idea about the diagnosis? This is a post-contrast delayed gadolinium enhancement image. You notice that there is severe concentric hypertrophy of the myocardium. Any idea, any suggestions about the differential possibilities? Shouldn't be right. That's fine. You can chime in. Okay. Okay. Let me.
Hypertrophic cardiomyopathy, familial,
Okay. This is an excellent thought. Yeah.
with induced fibrosis, myocardial fibrosis.
Okay. There is extensive myocardial fibrosis because of that severe enhancement that tell you that there is either severe scars or advanced infiltrative disease process. Yes. These are wonderful thoughts. Yes. Particularly, this is a 15-year-old. Okay, let me tell you, this is a very good thought, and I think many of us encountered in such situation, and we'll call it hypertrophic cardiomyopathy. And this was a patient with Danon disease. Any idea on any of those features is more a little bit suggestive that this is Danon disease rather than HCM? Like, what's the imaging feature in Danon disease? Is it LV wall thinning and dilation? Is it more common in females? Is it extensive LGE with septal sparing? Or I have never heard about this disease. Okay. The answer is extensive LGE with septal wall sparing, relatively. So let's talk about Danon disease. It's an X-linked dominant disease, genetic defect of lysosomal associated membrane protein 2 gene, lead to accumulation of glycogen in the myocardium and in the LV, particularly, and the RV as well. They thought initially that it's a glycogen storage disease, but it's not. It's a genetic defect of one of the gene proteins, lysosomal gene proteins. It is characterized by a triad: cardiac disease, mental or intellectual deficits, and myopathy, skeletal muscle disease, usually associated with conduction abnormality, Wolff Parkinson conduction white syndrome on EKG. So these are characteristic features, but still, some patients may just manifest early on cardiac rather than skeletal muscle disease, and may present like this and not the classic triad and not the classic EKG, and we can miss it because we didn't think about it. But it's a really this is the LGE image, and it shows that extensive enhancement suggestive of scarring or infiltrative disease process in the walls of the left ventricle. This is the left ventricle, this is the right ventricle, this is the septal wall. There is relatively less involvement of the septal wall when compared to the rest of the myocardium. This is one of the characteristic features. So massive HCM, significant HCM, and hypertrophic cardiomyopathy with non-uniform LGE and lesser septal wall involvement. As you mentioned, hypertrophic cardiomyopathy is a very
Josh, we didn't scan this guy, Clay Stefan,
uh,
tomorrow.
I'm sorry, guys. Can you mute yourself? Thank you. So hypertrophic cardiomyopathy is a important differential possibility, but in LGE, usually with HCM, they usually affect the RV insertion sites along the septal wall. Start with that. And Danon disease is the opposite, involve the septal wall really less when compared to the rest of the LV myocardium. So this is a differentiating point, but still some cases may be challenging. And Danon disease, an X-linked disease, means that it affects predominantly men, but also females can be carriers, and females can manifest only cardiac, not the classic triads. There's a little bit some differences. Okay, you can take a breath and dive into the other case that we have. 60-year-old female referred for evaluation of right ventricular dysfunction. And this is a quick case. I just brought it so you can take some rest in between the heavy cases. And I'm encouraging any trainee to take the lead. So any patient with RV dysfunction, we want to evaluate secondary etiologies to RV dysfunction if there is any evidence of shunting. This patient did not have ASD or intracardiac shunt to suggest that there is intracardiac shunts, and there are no imaging features to suggest intracardiac shunt, but there was RV side enlargement. Do you see any other vascular shunt that can explain patient's manifestation of RV dysfunction? I'm scrolling through the images. I'll give you some time. Okay. Any volunteer? So I stopped on this image. That SVC is a little bit larger than what we usually see. It's almost near to the size of the ascending aorta. So enlarged SVC, and at the same time, the pulmonary veins are from the right upper lobe.
Partial anomalous venous return.
Yes, excellent. So
in the superior vena cava.
Yes, so partial anomalous pulmonary venous return from the right upper lobe to the SVC. And this can, in some patients, may be asymptomatic, but when they are more than one vein, it may start to, with a prolonged time, like this patient is 60-year-old, may start to affect the right ventricular function. And it's reported that it is 0.4 to 0.7%, but I think it is, we see it a lot, and has been reported that the right upper lobe pulmonary veins to the SVC are the most common subtype, but followed by the left upper pulmonary vein draining into the left brachiocephalic vein. Uncommonly, drainage can occur to the other places like inferior vena cava or coronary sinus. But once I identify those veins on CT or on MR, I double check if this patient had ASD. It's very common. Like almost all sinus venosus defect patients has partial anomalous pulmonary venous return, like above 95% of them. And 6% partial anomalous pulmonary venous return can be seen in ASD patients. So it's very important that once you identify those veins, that you double check if this patient had ASD associated. And vice versa, if you saw a patient with ASD, you want to check if this patient had partial anomalous pulmonary venous return, because it will make a difference in the management plan and surgery. Okay. This patient, 56-year-old woman, presents with shortness of breath, weakness, and abdominal pain. Okay. This was the true FISP images from starting from the scan itself. that they start with those initial images before they plan for the heart. And it shows that when I stop the images over here, you can start to see some abnormality affecting the heart. You start to see the lung parenchyma is very visible, that you can say maybe this patient has some pulmonary edema, some trace of effusions, but also the heart does not look normal. Like there is excessive soft tissue thickening surrounding the aorta, surrounding the SVC, and when I go up, it's extending all the way to the proximal arch, and when I go more down, I see some soft tissue thickening here along the anterior atrioventricular groove, AV groove, and along the atrial wall. So let's see other views. This is a stack of short axis views through the entire heart from the atrial level down to the middle segment of the heart. And this confirms again what we saw initially, that this is not a normal atrial wall. This is a very thick atrial wall, almost like the size of the thickness of the wall is like the thickness of the ventricle. So there is abnormal thickening of the atrial wall. There is abnormal thickening adjacent to the soft tissue thickening of the aorta wall as well. And the more I go to the middle segment, this is the right coronary artery. And you see, this is a beautiful image, shows the right coronary arising from the right cusp, and it is significantly surrounded by a soft tissue infiltrative disease that goes around that right coronary. And again, this is the soft tissue thickening, soft tissue thickening, soft tissue thickening. Now, let's see other views. This is the 4-chamber steady state free precession images. Shows the that soft tissue thickening surrounding the right coronary and AV groove extending anteriorly to the anterior to the RV free wall, and there is soft tissue thickening of the atrial wall, maybe sparing the foramen ovale a little bit. But also, you can see some soft tissue thickening surrounding the left circumflex. Here, a 2-chamber view, again, soft tissue thickening surrounding the atrial wall, the AV grooves, and extending along the atrial wall. Okay. This is a small field of view of the aortic valve, but it's a really good view that I use it many times to look at the interatrial septum. But here it's showing the right atrium is wall is very thickened, and the interatrial septum is very thickened over here. This is the post-contrast LGE images and shows extensive enhancement of the areas that we suspected there is some soft tissue infiltration. What do you think the diagnosis is? Do you think it's lymphoma? Do you think it's cardiac angiosarcoma? Do you think it is infiltrative disease? Any thoughts?
I think infiltrative disease, as lymphoma and angiosarcoma, usually involve the right side.
Okay, that's a good thought. Also, angiosarcoma may be a little bit extend more intracardiac rather than extend along the aorta. This is another thought. Lymphoma, usually the patient has some markers, some lymphadenopathy. So all these are good thoughts, and we will start to think, oh, if this A and B are less likely infiltrative disease. Like, is it infiltrative disease process? Let's see the other images for the same patient. This patient had additionally some images of the abdomen and CT scan of the chest, and we had that single view from the cardiac MRI shows that extensive soft tissue thickening along the atrial wall and AV groove. And the abdomen shows extensive perinephric soft tissue infiltration here, bilateral perinephric infiltration. And there is bilateral interlobular septal thickening throughout the lungs. This, when you see that picture, you want to start to think of a multi-system disease that involve the heart, involve the lungs, involve the abdomen as well. And they did biopsy of this patient, and it was Erdheim-Chester disease. It's a rare non-Langerhans cell histiocytosis disorder. characterized by xanthomatous infiltration with a varied clinical presentation. They may present with osseous disease or with abdominal disease or with cardiac disease, such in this patient. May manifest in the 5th or 7th decades of life. It's slightly more common in men. The cardiac imaging manifestation usually soft tissue infiltration and thickening of the pericardium, AV groove in right atrial wall. The soft tissue infiltration may surround the right coronary artery. Vascular involvement, soft tissue infiltration of the aorta, like coated aorta appearance. But also vasculitis may give you some aorta wall thickening. So we need to be really thinking broadly, but this is a multi-system disease. Okay, good job. Now you are surviving me. This is a 24-year-old pregnant female. Came with dyspnea on exertion, and she has been known to have restricted perimembranous VSD since childhood that was not affecting any functionality of the patient or any symptoms. And these are the steady state free precession and 4-chamber views on multiple images. And do you see anything that catch your eyes? So the function of the ventricles looks within normal. Just there is some flow acceleration here near the right ventricular outflow here. Let's see more views. This is a short axis view near the basal segment of the heart, and it shows the right ventricle, left ventricle. And again, this is a flow acceleration through that region. And you can see that there is some narrowing here by a muscular bridge or ring of tissue here. This is a 2-chamber view or outflow view of the right side, right atrium, right ventricle. And here near the right ventricular outflow, you can see some flow acceleration as well. This is a patient with double chambered RV, right ventricle. It's uncommon situation, but they call it subinfundibular stenosis. It's subpulmonic stenosis, ring of tissue that causes some narrowing of the right ventricular outflow. They call it 2 chambers because that ring of tissue divide the right ventricle into 2 chambers, like a proximal one that high pressure, and a distal one that it's a little bit a lower pressure. And it is that ring of tissue that we saw the flow acceleration because of that narrowing. And this is another view of it, on the short axis view, showing that ring of tissue and the flow acceleration. It's commonly associated with perimembranous VSD. So anytime they mention that this patient with a history of VSD, or it's like 90% of those patients are associated with VSD, I double check if there is any abnormal muscular bands or any ring of tissue in the right ventricular outflow. So it is detected in 10% of patients undergoing VSD repair and can be associated with any other abnormalities. I think I saw it with tetralogy of Fallot patients or patients with mainly right side heart congenital pathology. So it's usually when you identify a right side pathology like tetralogy of Fallot patient or pulmonary stenosis, you want to double check your right side, like right ventricle, abnormal muscular bands, tricuspid valve. You check the pulmonary arteries as well. Patients are usually asymptomatic, like this patient, and when there is right ventricular outflow obstruction is significant, like in this patient, because she is pregnant, she has got some higher RV load, she starts to become symptomatic dyspnea, and the symptoms may vary but can be severe as RV failure. This is a companion case, 18-month-old child, 18-month-old child with a large perimembranous VSD. And this is the ring of tissue causing some narrowing of the RVOT, and this is the sagittal view. I want to show you the perimembranous VSD in this patient on the CT here. This is the ring of tissue causing some narrowing of the RVOT. And this is reconstructed images, shows the ring of tissue, shows the perimembranous VSD. Okay, this is a patient that was really a learning experience for myself. It's to double check myself. 75-year-old African-American woman, history of chronic AFib, and she had a remote history of repaired sinus venosus defect when she was 23 years old. And now she's presenting with dyspnea on exertion. This was her initial images, steady state free precession in 4-chamber view, showing significant large left atrium, some mitral valve regurgitation, also some tricuspid valve regurgitation. And this was her short axis view through the atria. And I will give you a chance to look at the images, and I'll go to that question. What do the MR findings indicate in this patient? Normal post-surgical repair, recurrent sinus venosus defect, or abnormal cavo-atrial connection?
C. Abnormal cavo-atrial connection.
Excellent. Why do you say that? Why did you choose C?
A connection between suprahepatic portion of IVC and the left atrium.
Yes, excellent. So we used to get used to that view a lot, that IVC should go to the right atrium, but in this patient, the IVC is going to the left atrium, which is hugely dilated. What happened in this patient is in advance, during the surgery, sometimes they may see the valve, and they reconstruct the atrial septum when they manage the sinus venosus defect wrongly, and instead of diverting the IVC into the right atrium, they diverted it onto the left atrium. And this is coronal view showing the IVC, and it is terminating in the hugely enlarged left atrium. And this patient had that repair like when she was 23, and she was manifesting as 75-year-old. And African American, usually you would expect that this to be right to left shunt, so you would expect those patients to be cyanotic, but in African American patients, maybe it was hard for them to detect the cyanosis. So it's very important to also know the direction of the shunt, what to look for. And again, this is view showing the IVC connected to the left atrium. Sometimes they mistakenly see the valve into as the dividing point, and they may connect it wrongly. And this is another view, this is the IVC going directly into the left atrium. It's very important that you don't take things for granted, like, oh yeah, the IVC should go to the right atrium, but it was unexpected to see the IVC connected to the left atrium. This patient has underwent surgical correction of the IVC, and they connected to the correct side, right atrium. They reconstructed the atrial septum, and you see here that there is significant decreased size of the left atrium. Also, they repaired the mitral valve to control the regurgitation a little bit. So, and everything went well for this patient while she is 75-year-old. Abnormal caval drainage to the atrium can occur as a rare congenital anomaly or iatrogenic, so we can pay attention. And the manifestations or the symptoms can happen immediately after surgery, as we would expect, but also may even take years. So in those patients, we need to really fully evaluate and be aware about this condition. Okay. This is another learning case for me. This is a 50-year-old from, I think just recently I came across this patient, 50-year-old female, hypertension, new heart failure, admitted from an outside facility. They did a cath for this patient to evaluate the coronary arteries, and they didn't find any obstructive coronary artery disease. So they called it, this patient probably have non-ischemic cardiomyopathy. And our CT tech, our MR tech are really, and CT tech are all great. Just our MR tech started scanning this patient, and she noticed that images. This is the steady state free precession, not the cloudiness of this blood pool. The images are really dark, and maybe there's something. They checked the overlying leads, if there is any metallic devices in the overlying the chest and abdomen that causes this inhomogeneity of the field, but they didn't find something to explain that. So they proceeded with the images, and still when they were doing the short axis, still the images are really cloudy. There is a significant dark signal of the liver. So they swapped to gradient sequence, but there was really abnormal myocardial brightness on the gradient sequence and abnormal dark signal of the liver and spleen, and we didn't know. So they gave me a call, and they told me, oh, we were running the perfusion test. They usually take that perfusion test before injecting the contrast. And they told me, oh, we saw as if this patient had a contrast, but this patient did not have any contrast injected. We double checked the injector. We double checked we didn't load the injector even with the contrast to call that this patient had received our gadolinium-based contrast like by a mistake or something. So they called me and they told me what to do next. So I would raise the same question. Shall they proceed and inject contrast? Any thoughts on what could have happened and why we have these images, or what I should do next?
Data start.
Okay, that's a good thought. We were scanning on 3 Tesla scanner. I didn't mention that. So we usually prefer to do the T2 star on 1.5 Tesla, but this is a good suggestion. And I thought the same thing. Maybe this patient had iron overload. So I looked at the native T1 maps, which we do it before the contrast, and this is 3 Tesla scanner, 753, and these values are significantly low values to the T3 scanner. So, and you know that native T1 values are expected to be low in iron overload, but I checked the patient story, and the ferritin, the iron levels on this patient was really within normal or even lower. Like this patient may have some iron deficiency anemia a little bit. So I was confused. This patient not known to have any iron overload, no hereditary history, and low native T1 values, but this is a good thought. Any other thoughts? And the contrast was really bright on the perfusion test. That it's not a perfusion test. It's like images that they obtained before injecting the contrast. So nothing wrong with the contrast injection. We didn't inject the contrast yet. We checked the lab for iron overload parameters, and this patient did not have any iron overload parameters on lab. We stopped scanning and called the technical support team for the machine. And also the machine gave us an error that there is some error. So maybe it's a technical, and we decided to reschedule this inpatient. This patient was hospitalized at that time, and we decided to rescan this patient once the machine is checked by the technical support team. And we scanned this patient 2 days later. So images are a little bit cloudy, inhomogeneous. Everything is dark with the signal images, and there's some mitral regurgitation, left atrial dilation, some LV dilation as well. But when the whole day, the scanner was totally fine. The patients looked beautiful images, but still when they did that image before contrast injection, the blood pool is bright, and they didn't inject yet any contrast. So they called me again to check. So at that time, I consulted a cardiologist colleague, and I told him this patient does not have any history of iron overload. His iron parameters are within normal. So how come the images are dark, low native T ones, and showing me a bright signal on imaging? And we don't use iron-based contrast. I'm curious to see if any of my colleagues here in NASCI are using the iron-based contrast material, because we don't use it in our institution yet. But iron-based contrast, we didn't use any iron-based contrast in our lab, CMR lab. So do you have any explanation that this patient have? And I don't see any history of iron. And surprisingly, he told me that this patient received ferumoxytol injection just 2 days before the scan time. And this is a recent through the recent guidelines, they are using it for management of heart failure and iron deficiency anemia, particularly with some national shortage of some medications to treat iron deficiency anemia and end-stage renal disease. So, and it is a member of the ultra small super paramagnetic particles of the iron oxide, which disrupt the MR magnetic field. And that really explained what we were seeing and why images are disrupted that way. And still, it's used. Just be aware about that. That the peak of disruption of the MR signal will be peaking 1 to 2 days after the injection of that dose to treat the heart failure or iron deficiency anemia, and usually it lasts for 3 months. And usually MR before 4 weeks will be before 4 weeks after the injection will be a little bit disrupted. Just be aware about that injection and how it affects our cardiac MRI. Okay, do we still have time? Yes. So one more case or 2 more cases if we have time. This is 36-year-old Caucasian man, had a cardiac arrest after driving his go-kart. He had a history of alcohol use, and they took this young patient into a cath lab, and there was a normal coronary arteries, no evidence of obstruction. This was his initial imaging, showing the steady state free precession images of the heart, showing a relatively normal heart function, like 53% after cardiac arrest, and everything was relatively looked fine on those initial images, 3-chamber view and 4-chamber view. And then in those patients with cardiac arrest, I usually ask to take some extra 4-chamber views to assess the RV free wall a little bit much better. And here, along the inferior aspect of the 4-chamber view, you start to see that there is that India ink artifact along the apical segment of the interventricular septum. And with inside is a high signal intensity, you start to doubt that this is a fat within the myocardium. This is a short axis views, and you start to see these, the function looked within normal, but you start to see that abnormal high signal intensity surrounded by a dark signal India ink artifact suggestive of fat deposition within the inferior interventricular septum. These was the were the LGE images of this patient, and any thoughts about the pattern of enhancement? Do you see any enhancement?
Right ventricular wall enhancement and some septal wall.
Well, the RV free wall, this was a epicardial fat incomplete suppression. I apologize about that. It's similar to the subcutaneous fat, but this was the abnormality. You see that ring-like enhancement
At the inferior septal or at the insertion point.
and along the inferior wall. It's subtle, but you can start to see it here. It's along the septal wall, inferior wall, and extending to the lateral wall as well. And this is other views to see it much better. This is the enhancement here. So it's mainly subepicardial and mid-myocardial enhancement pattern. I think here along this is a 2-chamber view, left atrium, left ventricle, and this is along the inferior wall. You start to see that subepicardial to mid-myocardial enhancement pattern. This was the native T1 values showing some elevation. I think the images are not that clear, but it showed some elevation along the sites of the enhancement, and that dark signal in the location of the fat deposition in the interventricular septum. So this patient was taken to testing. It was positive for desmoplakin mutation, which is a type of arrhythmogenic left ventricular cardiomyopathy. And usually they have normal size to slightly dilated left ventricle, normal to slightly reduced LV function. Usually they have a preserved LV function till later. But the enhancement pattern usually comes before the systolic dysfunction in those patients. And this patient had underwent some the ICD placement, left axillary placement of the cardiac conduction device, and this is overlying the chest wall. For the diagnosis, usually PADWA criteria are helpful. And it's so LV arrhythmogenic cardiomyopathy is usually exclusively associated with desmoplakin mutation. Usually the LV function is preserved, but if it starts to decline, it's very associated with severe ventricular arrhythmias. And these are the PADWA criteria. Major criteria is when you see some enhancement in a stria or band distribution involving more than one segment of the myocardium. And subepicardial and mid-myocardial enhancement is characteristic enhancement pattern. And usually we wouldn't count for the RV insertion sites because sometimes you see some septal RV septal insertion sites in many patients that are non-specific. So we are not counting that. And usually when there is positive genetic test or family history, this is a very highly suggestive for the diagnosis. Mimics, just be aware that post-COVID myocarditis is a mimic for this patient. Like in this patient, he was a 20-year-old man with a history of COVID, post-COVID myocarditis, and you see some enhancement along the myocardium, mid-myocardial to subepicardial. And this is another patient with sarcoidosis, also characteristic by some subepicardial and mid-myocardial enhancement, but usually it's patchy rather than a ring-like distribution. But this is a case of advanced sarcoidosis. You can see the scar tissue involving most of the left ventricle here. This patient underwent heart transplant later on. Okay, we can, 1 minute or 2 minutes, we can take another last case. What's the vessel indicated by the arrow? I know all of you tired now. Is it aorta? Is it duplicated IVC? Is it azygos? Is it pulmonary vein? This is an azygos vein. How come the azygos vein in this patient is similar to the size of the aorta?
Absent IVC or interrupted IVC?
Yeah.
Okay.
Excellent. So either sometimes maybe occlusion of the IVC if this is not a congenital case, but this patient had a polysplenia syndrome. It's multiple spleens, characteristic by multiple spleen. You see here in the left upper abdomen, the multiple spleens as splenial or enlarged.
Yes, okay.
And relatively midline liver, interruption of the IVC, and subsequently the azygos vein act as another IVC to drain into the SVC. And this is another view. And this patient had severely enlarged right side of the heart, right atrium and right ventricular enlargement, tricuspid regurg. And once we see that enlargement, you want to suspect shunting left to right. And the RV function was really, the end diastolic volume was elevated for 100, and the index also was elevated. So you are concerned that this patient has significant shunting. The QPQS was 2.9 based on the stroke volumes and based on the QPQS, the aorta and pulmonary flows. And on a close-up on the steady state free precession, there is dilation of the pulmonary artery, but at the same time, that septum is directed posteriorly, inserting into the posterior wall. So, and you can see that here the right lower lobe pulmonary vein is inserting into the right atrium. So you would start to suspect that the pulmonary vein is draining, but as we mentioned, a single pulmonary vein draining into the atrium should not cause that significant dysfunction. Yes, over time can happen, but let's review the CT scan that was performed in this patient, because there was some artifact on the MR. And on the CT scan, you start to see that that septum is inserted posteriorly near the midline. The veins from the entire right lung veins are inserting into the right atrium. So this is what we call malposed interatrial septum. Instead of inserting this way, it's inserting posteriorly near the midline. And as a subsequently, all the veins from the right side of the right lung is inserting into right atrium. So this is causing significant shunting, and this patient has underwent surgery. Here is another view. This is the right lower lobe pulmonary veins. This is the right upper lobe pulmonary veins, and this is the intraatrial septum. It's a rare congenital anomaly. It's poor development or absence of the septum secundum can result into this appearance of the septum primum inserting posteriorly near the midline. And redirection of the pulmonary veins toward the right side will result into significant left to right shunt. Okay, this was my last case. Any questions for me?
I have a question regarding the previous case, the one with the arrhythmogenic LV. Looking at the four-chamber view and also the short axis, I was wondering if there is also some sort of dyskinetic regional dyskinesia involving the RV.
That's a really good thought also, because once you see any RV enlargement, you want to make sure is this patient is one of the possibilities that ARVC, and of course, because of that significant dilation, there is abnormal hypokinesis of the wall motion of the RV free wall. Yes, like it's significantly hypokinetic because of that significant elevation of the RV volume. Even the pressure becomes a little bit higher. You start to see that there is some tension on the interventricular septum bowing into the left side. Excellent observation, but you want to exclude ARVC. But once you identify the shunt, it's highly suggested that this enlarged RV volume from the shunting, and particularly if it's a significant shunt. This is one thing, but any RV enlargement and wall hypokinesis, you want to suspect other etiologies. You want to exclude intracardiac shunt. You want to exclude vascular shunt. You want to exclude ARVC or arrhythmogenic right ventricular cardiomyopathy, or sometimes pulmonary hypertension because of secondary etiologies like lung disease. Excellent. Did that answer your question?
Yes, thank you so much.
Sure. Any other questions or case discussions for me? Team, you are all wonderful. I really appreciate that you all participated in the discussion. And it's a great pleasure for me to participate today, and Happy New Year, everyone.
Thank you.
Thank you.
Thank you.